Hi, my name is Dr. Jason Westin from MD Anderson Cancer Center, and it's my privilege to present the updates from 2025 for patients with lymphomas. We'll start off with diffuse large B-cell lymphoma, the most common lymphoma subtype, and there were a number of important updates this year. First, we'll start with a trial that was presented at the ASH 2025 meeting, focusing on the novel CELMoD agent called golcadomide. Golcadomide is an oral agent that can be combined with other treatments, and in this study, it's being combined in patients with newly diagnosed diffuse large B-cell lymphoma, along with the standard chemotherapy R-CHOP. Golcadomide, as mentioned, is a CELMoD agent, and it has a specific targeting of Ikaros and Aiolos, resulting in a rapid degradation of these proteins, which has significant immune-facing properties as well as tumor cell intrinsic cytotoxicity. It has advantages over previous similar compounds such as lenalidomide in that it has a much greater specificity for converting the inactive or open cereblon to the active or closed cereblon, which has a much greater impact on Ikaros and Aiolos within the target organs. This is the schema of the clinical trial, looking at two different dose levels of golcadomide, oral days 1 through 7, combined with R-CHOP, evaluating in this phase 1b clinical trial. Patients were adults with newly diagnosed large B-cell lymphoma. The results are shown here, showing to me, a very impressive finding of a complete metabolic response rate of close to 90% in patients treated at the zero point 0.4 milligram dose, regardless of their clinical risk features. Patients with high-risk disease and the two different types of cell of origin all had similar excellent results. The progression-free and overall survival were quite impressive, and in this high-risk patient population, at 2 years, the overall survival was approximately 90% in both groups, which to me is greater than what we would expect for standard treatment alone, implying that golcadomide hopefully has some impact here. And this leads to the phase 3 clinical trial called the GOLSEEK-1 trial, which is combining R-CHOP with placebo compared to R-CHOP plus golcadomide, randomized 1-to-1, with the results being eagerly anticipated around the globe. Next abstract to present as an update this year is Rapcabtagene Autoleucel, formerly known as YTB-323. This is targeting patients with large B-cell lymphomas as an autologous CD19 CAR T-cell product. But what's quite unique in this clinical trial is it's targeting patients with two risk factors. Patients have baseline high-risk disease, defined as an IPI of 3 to 5, and/or double-hit lymphoma. That's criteria number one. Criteria number two is that patients have 2 cycles of standard chemotherapy and have a poor response, have a Deauville score of 4 or 5. So baseline high risk, poor response to chemotherapy, and then they're eligible for this phase 2 clinical trial where they receive Rapcabtagene Autoleucel as a attempt to overcome those two risk factors. Rapcabtagene has rapid manufacturing, which can be delivered in approximately 2 days manufacturing time frame from apheresis, which is much faster than what we've seen for some of the earlier products that are FDA approved. In this study, the primary endpoint was complete response rate, which was seen in 74% of patients on this high-risk frontline study. Overall response rate of nearly 90%. The duration of response is impressive, showing that patients with a complete response have very favorable outcomes, but I'll also note several patients with partial response had ongoing response at the time of the data cut, which I think implies that these partial responses probably are actually eradication of disease and may show some false positive inflammation on a PET scan. So that 74% complete response rate, I think, is quite impressive. Progression-free survival thus far looks much better than what we would expect for chemotherapy alone for this double high-risk group. And notably, the cytokine release syndrome, which is the rate-limiting toxicity for many CAR T-cell products, was quite low, with all told uh, about about 49% of patients on the study having any grade CRS, but the vast majority of those patients had grade 1, which is a fever only. Only 11% of patients had anything more than a fever. So 89% of patients had no clinically significant CRS. The other thing that's notable on the toxicities for this CAR T cell rapcabtagene is that the time to onset for the cytokine release syndrome after infusion of the CAR T cell product was 11 days, which is much longer than what we've seen from prior products and may allow for outpatient therapy. So in conclusion, in this double high risk group, Rapcabtagene showed a very high complete response rate, which was durable, and a very low rate of cytokine release syndrome. And I think we can eagerly anticipate future clinical trials evaluating Rapcabtagene in patients with B-cell lymphomas. The next important update is from the ASH 2025 meeting presented by Bjorn Chapuy on behalf of his co-authors, looking at a frontline chemotherapy light regimen called R-Pola-Glo, polatuzumab and glofitamab, in patients who were unfit and frail with newly diagnosed aggressive B-cell lymphomas. Rituximab has been around for 20 plus years, of course, a CD20 targeting antibody. Glofitamab is a novel agent targeting both CD20 and CD3, CD20 on the malignant B cells, CD3 on the T cells, the so-called bispecific antibody, which has been approved in multiple countries around the world, and polatuzumab vedotin, the antibody drug conjugate targeting CD79B. This triplet was studied in patients who were elderly or unfit for chemotherapy, and patients were treated with an initial step-up dosing, obinutuzumab to debulk the circulating B cells, polatuzumab, and then step-up dosing of glofitamab, as done in prior trials, to achieve the target dose. And then patients would go on to receive a total of 12 cycles of glofitamab. The response rates on the right-hand side at the different time points after course 2, after course 6, and at the end of cycle 12 show that more than 80% of patients achieved a complete metabolic response despite receiving no conventional cytotoxic chemotherapy. I think this is quite impressive with an overall response rate at end of treatment of 90%. So very, very promising results showing that without conventional chemotherapy, significant activity can be seen in terms of early responses. And looking at the 1 year progression-free survival and overall survival, both approximately 85 to 90%, showing excellent outcomes in this unfit, frail group. But the toxicities, I think, are also quite notable, and that cytokine release syndrome, which sometimes can be a rate-limiting step for bispecific antibodies, was quite rare. About a third of patients had any grade of CRS, but grade 3, which is a trip to the intensive care unit, was only seen in one patient, 1% on this clinical trial. So overall, very low and infrequent CRS was seen on the study. The rates of ICANS, 3 patients total, 4% had any grade of neurologic toxicities. Thankfully, that's a very low rate, which we hope would see in future clinical trials in this space. And then lastly, an abstract that I presented at the ASH 2025 meeting for an investigator-initiated trial looking at the primary analysis of the SMART STOP trial. This is a study evaluating lenalidomide, tafasitamab, rituximab, and acalabrutinib, a 4-drug combination in patients with newly diagnosed large B-cell lymphoma. We presented the results at the 2023 meeting of the initial cohort where patients who had a complete response to this lead-in for newly diagnosed aggressive B-cell lymphoma would have a PET scan and then a response-adapted treatment. In the abstract that we updated at the ASH 2025 meeting, patients who had a complete response to the chemotherapy-free lead-in LTRA or Ultra received no cycles of chemotherapy. So first of its kind to evaluate a 4-drug combination and trying to reduce or remove chemotherapy. What we found is that patients who had the 4 cycles of Ultra and then had the PET-CT scan in this most recent cohort, 57% of patients had a complete response after 4 cycles of lenalidomide, tafasitamab, Rituxan, and acalabrutinib, which is quite promising. The overall response rate was 90%. When we look at the complete response rate at the end of all treatment, we found that it was nearly 97%. Very high results for a frontline large B-cell lymphoma to have dose reduced or dose removed CHOP chemotherapy. The progression-free and overall survival thus far on the clinical trial appear very favorable for this high-risk group of frontline large B-cell lymphoma patients. And in conclusion, we've now shown in two studies that the SMART strategy of targeted therapy first is successful and it preserves curative intent. That several patients on this study had outstanding outcomes. I shouldn't say several. Nearly every patient on the study had outstanding outcomes. After 2 cycles of CHOP and 6 cycles of Ultra, thus far, no patients have progressed. For patients who went on to get no cycles of CHOP on this clinical trial, just 10 cycles of lenalidomide, tafasitamab, rituximab, and acalabrutinib, about a quarter of those patients have gone on to progress. However, all thus far have subsequently had a complete response to conventional chemotherapy, implying that trying the SMART strategy first does not damage the ability for chemotherapy to work if patients don't benefit from targeted treatments. And we're hoping to see randomized trials evaluating these targeted combinations with response-adapted treatment randomized against standard chemotherapy alone. An important update that was published in the JCO this year was presented at the ASH 2024 meeting, but as mentioned, published in the JCO during 2025. 5-year follow-up of the POLARIX study, um, which POLARIX was R-CHOP randomized versus our CHP polatuzumab, frontline large B-cell lymphoma. The initial progression-free survival improvement in the overall population showed durable separation of the curves with 5 years of follow-up. The overall survival does show a minor separation of the curves out on the far right hand of the figure. However, this is not statistically significant. And now with mature follow-up, I think we can say progression-free survival clearly superior. Overall survival is no different between the two treatment groups. Briefly moving on to updates in follicular lymphoma. This is data that was published and approved by the FDA during 2025. Tafasitamab plus lenalidomide and Rituxan for patients with second-line follicular lymphoma, the so-called INMIND trial. This randomized patients to receive either lenalidomide Rituxan or the so-called R-squared regimen, randomized against the same regimen plus tafasitamab, the CD19 monoclonal antibody. The primary endpoint was progression-free survival. Here is the progression-free survival curves showing a hazard ratio of 0.4, obviously very statistically significant. The time to next treatment also highly significant between the two groups. And overall survival has a hazard ratio of 0.59. The confidence interval does cross 1, but does have a positive trend on this early readout for overall survival. We know that follicular lymphoma, thankfully, is a disease that can often be treated with multiple lines of therapy and takes a long time to see outcomes. So let's stay tuned to see if there's updates on overall survival. But there is a separation of the curves, not yet statistically significant. Published after the ASH 2025 meeting and subsequently approved by the FDA is another clinical trial comparing lenalidomide rituximab versus lenalidomide rituximab plus a different agent. This time, epcoritamab, the CD20 CD3 bispecific antibody in the EPCORE FL1 trial. This trial, similar design to the INMIND study of randomizing patients to receive either R squared versus R squared plus the novel agent. Here, EPCO shows a very significant improvement in the primary endpoint of progression-free survival with a hazard ratio of 0.2, highly statistically significant, and clearly does not need a statistical test to show that these are quite different results. For progression-free survival. Here is the time to next treatment, which is quite important for indolent lymphomas. And here is overall survival, which does achieve statistical significance, a hazard ratio of 0.38. So clearly superior across all metrics for EPCO R squared versus R squared. So in conclusion, practice-changing studies in 2025. Diffuse large B-cell lymphoma, RCHP POLA improves progression-free but not overall survival. And I showed you a number of novel studies that don't yet improve standard practice, but I think have the potential to do so based on multiple randomized phase 3 trials ongoing. And last but not least, follicular lymphoma. Both Tafa-Len-R and EPCO-Len-R are both dramatically superior over Len-R or so-called R squared. and it should be viewed as a new standard of care in second-line large B-cell lymphoma. And with that, I will thank you for your attention.